guess we're ready to go. Welcome, everyone. We're ready to restart. It's good to see you all back. Hope you had a nice coffee break and got to see the posters. So my name is Dan Herman. I'm a professor and associate dean at the Silberman School of Social Work of Hunter College, located on 119th Street in East Harlem. And thank you for inviting me to, I was actually part of the planning committee for this meeting, and I appreciate being invited to participate in this last panel of the day. So let me start out by introducing the four panelists. Very briefly, you've got longer biographical descriptions in your program, but just to refresh your memory. First is Professor Daniel Gardner, who's also on the faculty of the Silberman School of Social Work at Hunter College. He's the research director of the Hartford Silberman Center of Excellence in Gerontological Social Work at Hunter. And his current research focuses on exploring and developing interventions to address health disparities in pain management and palliative care among low-income minority elders. And then to his left is Dr. Faye Rim. She's currently acting chief of the Department of Pain and Palliative Medicine at Metropolitan Hospital. She's board certified in physical medicine and rehabilitation, pain medicine, and hospice and palliative care. And she also serves as the New York Medical College Hospice and Palliative Medicine Fellowship Director and is a clinical instructor in the Department of Physical Medicine and Rehabilitation at New York Medical College. Next is Dr. Carrie Reed, directs Cornell's Center of Excellence in Geriatric Medicine and the Office of Geriatric Research, housed in the Division of Geriatrics at Weill Cornell, where he also serves as the director of Cornell's Edward R. Roybal Center for Translational Research on Aging. So his work over the last decade has been focused on the epidemiology and treatment of persistent pain disorders in older adults. And finally, Dr. Evelyn Reyes-Laureano is executive director of an agency called Neighborhood Self-Help by Older Persons Project, the acronym SHOP, which is an organization dedicated to empowering elders of color through advocacy, leadership training, and targeted services. Among Dr. Laureano's accomplishments over a distinguished 40-year career include the development of strength-based social work practice models with minority elders, the establishment of one of the first elder abuse programs in the Bronx, and prevention and wellness initiatives to reduce health disparities among elders of color. So it's a wonderful, diverse group of people and with diverse experience. So the way the panel is going to be organized is each of them is going to speak briefly for about 5 minutes, I understand, describing some of their work, and then we'll be able to have interchange among the panelists and also opportunity for questions from you all in the audience. So, Dr. Gardner.
Thank you. So, hello everyone. Good to see such a big crowd. Dr. Rim and I are involved in a project that actually is an offshoot of a larger consortium project that Dr. Reed is actually involved in as well. One of my jobs is working with the Brookdale Center of Healthy Aging, and along with Weill Cornell, we've been doing research that involved needs assessment, focus groups, key informant interviews in East and Central Harlem with older adults to see what their chronic illness needs are, what their symptoms are, what kind of services they're using, and what we can do to help people who are not getting access to services. I come from, one of my interests, as Dr. Herman said, is with health disparities. So one of the things I'm really interested in is the fact that we know that there are huge disparities in terms of older adults of color, older adults who are poor, in terms of a whole variety of health issues, but there's also a tremendous amount of disparities in terms of palliative care and hospice use. The other thing is that There's been a lot written about how in the last 10, 15 years, palliative care has just grown unbelievably fast throughout hospitals. That hasn't necessarily been as reflected in public safety net hospitals like Metropolitan. So my involvement with Metropolitan involves being on their community advisory board, and I originally approached actually Dr. Rim's predecessor and the predecessor of the medical director and the predecessor of the executive director at Metropolitan about doing a study that looked at people, older adults at discharge who had had some consult in palliative care, and then followed them 3 months later into the community. And that's just to give you a little bit of background. What we're going to be talking about is some of the challenges and benefits of working together. The larger initiative is an initiative that is following more strictly community-based participatory research protocols, even though that has its benefits and challenges as well. We won't be addressing that as much, but I wanted you to know that there is a community council that we developed out of that is involved, that involves older adult residents, providers, faith-based leaders, and people who have really been with us the entire process long and are going to be helping to advise us as we do this offshoot study. The study, just to give the introduction, and then I'm going to pass along to Dr. Rim, is, as I described, is following the studies, but it's really to look at what the disparities are, what the perceptions of the older adult patient are, and to point us in the direction of interventions that are more specifically targeted to meeting the needs of older adults. Because one of the things we found from the larger study of a larger needs assessment is that there's a tremendous amount of burden out there, but there's not a tremendous amount of access and utilization of services amongst older residents of East and Central Harlem.
I'd like to preface that by saying the population we're primarily looking at is not just older individuals, but primarily ethnic older individuals, because our population is obviously in Spanish Harlem. So it's a lot of African American, Black, Latinos, and immigrants. And Metropolitan, and I'll give a little background on the hospital as well. So Metropolitan in its current iteration has been there since about the 1950s, 60s. And it's a safety net hospital, part of HHC, but it's also a community hospital. So it's very centered at delivering care to those who are underserved, don't really have access to medical services. There's a specific credo within our mission statement that we're not looking at ability to pay, and it's primarily to serve the community that it sits in. So the demographic is, again, primarily Latino because it's Spanish Harlem, but there's a large immigrant population as well. And it is a very underserved population across the board. It has about 350 inpatient beds. Its primary clinics serve anywhere from a little bit over 130,000 individual primary care visits per calendar year. The Pain and Palliative Care Department in its current iteration was brought into light in about 2007, and it was actually the first palliative care department within HHC, and it's probably one of the first palliative care departments in a public hospital setting nationwide. Like Dr. Gardner was saying, in the last 10 years, there's been an explosion in looking at the advances of palliative care and access to palliative care, and almost every hospital, especially in the New York City area, has some kind of palliative care service within the hospital. A lot of that is built on the model where its advantages are really on the cost-cutting aspect of it. Insurance companies really like palliative care. Hospitals like palliative care because part of the reason why it's been so popular is because of the whole cost versus quality type of issues. That becomes particularly burdensome in my population because you have a population that has been critically denied access to care. So when you talk about it in terms of utilization in a population that's been underutilized to begin with, it looks a lot like you're not accessing care. And that's a hypothesis that I take to heart, but at the same time, that may or may not be the generalization. So when Dr. Gardner came to me with this study, I thought it was a great idea because there really are not a lot of studies looking at my particular population and the utilization of palliative care and the perceptions of palliative care. So I've kind of like jumped on board wholeheartedly. Some of the issues has been that I kind of inherited this study, like he said before, he had initially broached my predecessor. And unfortunately, we've had a lot of turnover within our hospital system. HAC is a government entity. It is completely unlike trying to get research approval in a lot of private institutions. And so we've gone through a lot of red tape. There's the issues of just getting IRB approval. It has to be through a specific a university that the HHC is already affiliated with, so the CUNY IRB was not good enough. We had to go through our own IRB process. HHC then on top of that has its own research approval process. And so it's been kind of a learning process all across the board. And any issue that could potentially come up, even something as little as having one of his research assistants coming into the building and what kind of access they're allowed to have has become a point of contention. So it's been difficult to say the least, but I'm really hopeful that we can get some good data to basically look at the population and say what is and is not valid. And that's all I have to say.
Great.
My 5 minutes.
Well, I'm here with Evelyn Loriano. And again, my name is Carrie Reed, and thank you all for staying put on such a beautiful afternoon. It's obviously challenging, given that spring has finally sprung. What I'd like to do is start by giving you a little bit of background on a project that Evelyn and I collaborated on several years ago, and then each of us is going to talk about the benefits and opportunities that emerged both during and after the project. So, just by way of background, is estimated that 46 million U.S. adults live with chronic musculoskeletal pain, and those of us who work in clinical settings know that this is a major cause of disability and suffering, not only in those who experience the pain, but often family members as well, witnessing people who have poorly managed pain. We also know that as you age, that the prevalence and impact of pain typically will go up, and this is true as well in minority communities, if you belong to a minority group. So what do we do about it? Well, there are a variety of treatments out there. One of them that we focused on in this particular project was thinking about how to make use of evidence-based self-management programs. I've listed one. There are many that are out there, but perhaps the most well-known is something called the Arthritis Self-Help Program. First developed by Kate Lorig maybe 40 years ago, a nurse at Stanford, and the program has been adopted by the Arthritis Foundation as a tool for dissemination. But what we also know about the program and others like it is that it's really had limited reach. So it's been estimated that maybe fewer than 1% of U.S. adults with arthritis have participated in the program. These are typically 6 to 8 weeks in length. They're group-based. There's a variety of components to self-management programs. I've listed them here. Some skills training. So if you're in the program, you get to learn about relaxation techniques, other behavioral strategies for managing pain, a fair amount of education by virtue of the fact that it's a group initiative. There's a lot of social support that happens. And then some additional skills building, and that each week participants are asked to set a goal. So these goal-setting exercises are felt to build self-efficacy. So what was our project, which was a CBPR project that we entitled Taking Community Action Against Pain? We really had one major objective, and that was to adapt the Arthritis Self-Help Program for optimal use in older adults. with a particular emphasis on older Hispanics and older African Americans, with the idea that there are disparities in the management of pain, and therefore these groups were particularly worthy of attention. The hypothesis of the project was that by virtue of adapting a program for optimal use in these target populations, we could not only increase the reach of the program, but potentially its impact in these populations. So who were the partners in this? Again, this is a project that was completed just a few years ago. There were several New York senior centers, New York City senior centers that are listed here. Neighborhood Shop, Casa Boricua, where Evelyn is the executive director. We also had a senior center that was a primary partner in Central Harlem Senior Center. And then in the Bronx, a senior center that served almost exclusively non-Hispanic whites called Riverdale Senior Center. The Arthritis Foundation, New York City chapter, was another partner. And then the Cornell Institute for Translational Research on Aging was the third partner where the investigators were housed. So, as you heard this morning and throughout the sessions today, the importance of having some kind of steering committee or community advisory board, and that played a key role in this project as well, overseeing all aspects of the work. Representatives or stakeholders in this committee included seniors with chronic pain, elder service agency staff. We had people who were experts in the program itself from the Arthritis Foundations, and then the researchers as well. So what did we do? Well, one of the first challenges was to figure out a way to actually do the adaptation. And so the Community Advisory Board created an adaptation method. And it was really quite simple. That the sense was we needed to expose potential end users, people who might benefit from the program, to take the program, and then to solicit input from them around what they liked and didn't like, and how they might change it for settings that they were receiving services in. And we did the same thing for the people who were the instructors of this program. We then had to figure out, well, once we generated these recommendations, what would we do? And we met over a series of occasions where we adjudicated what were roughly 84 recommendations that emerged from this process, and this Community Advisory Board accepted about 40 of the recommendations. And they fell into a couple of themes. The first was that there was a strong sense that some elements of the program could be restructured to maximize learning. There was also a sense that we might want to modify specific program content, in particular to ensure that people taking the program could understand all elements of what was being presented. And another theme was coming up with ways to really try to support maintenance of treatment gains, which is a key issue in this kind of work. And we did this by educating individuals about ongoing programs in their communities where they may be able to keep up and practice some of the exercises they learned. So what were the principal or primary products of this? There were many. I'm listing just a few here. The first is we adapted. We were successful in adapting the arthritis self-help program, and then we did something that was relatively rare in this work. We took it back into the field and we compared it with the original program to see whether it made a difference or not. We were able to show that, in fact, there were far fewer people dropping out of the program because attrition has been an issue with this. So we had the significant reductions in attrition and significant improvements in class attendance. We did not show that the adapted program led to better treatment outcomes, but I think having better reach was certainly a positive outcome. The project also led to a method that others can use, has been published, about how one adapts evidence-based programs for use in diverse community settings. And then one of the senior centers, Central Harlem in particular, came up on their own because they felt this was such a good program, we've got to figure out a way to sustain it. And they created their own ongoing support group called Beyond the Pain, which continues to meet 3 years running. And I would say the other product has been sustained partnerships. And this is one of our class attendees, and this is what success looks like after you take the self-management program. Don't try this without taking the program. So I'm going to turn it over to Evelyn.
So This was a wonderful opportunity for our program in the South Bronx. Neighborhood Shop has a variety of services focusing on helping people to help themselves. That's our mission statement. And the idea of a community partnership really helped us in research because it was in line with what our mission statement was. It involved the participants of this research study to be involved in in shaping the program, in getting feedback about what was good and what was helpful to the program. And it also involved having town hall meetings in which the researchers reported back to the participants, this is what we found, this is what our findings are, and do you agree with them? So there was a lot of feedback, a lot of give and take. Our program is, it was completed at Casa Boricua Senior Center, primarily Latino, Puerto Rican, Dominican older adults, and the Arthritis Foundation book was in Spanish, but it was 300 pages. It was a big, fat book. And so the issue of literacy was a concern. Yeah, you take this class and you get handed a book and you follow the curriculum in the book. Was that going to be a practical matter for the participants of our program, where literacy may have been an issue? Our program, we serve about 5,000 clients a year. We have case management services for the homebound. We operate 3 senior centers. We have an elder abuse program and case assistance program. And what we found was the participation with this project really allowed us to leverage into other programs as well. Casa Boricua Senior Center has been named one of 9 innovative senior centers in the city as a result of the fact that we were involved in health promotion and innovative practices when it comes to wellness programming. So this was very helpful for us. We also I sat on the advisory council, as did the other 2 participant executive directors of the participants' sites, and we had an opportunity for input as well. And so we know who our seniors are, we know who our participants are, and we were able to provide that insight and that information to the researchers. So it wasn't just those guys up in the ivory tower. It was, this is what's happening at Casa Boricua. This is the, yeah, you have this wonderful 300-page book. What good is it going to do? Yes, it's in Spanish, but can my seniors read? So that was something that was a very helpful endeavor for us. Okay.
Thank you. Just a few other, let's go back. So from my perspective as a researcher, one of those pointy-headed academics who lives in the ivory tower, you heard today about what the benefits are of doing this kind of work. I would argue that I think it really is a method for enhancing productivity. We were able to submit a number of additional grants as a consequence of this work. We were quite successful in publishing all elements of the project, so there were a number of peer-reviewed publications that came out of it. I'd be happy to send those for those who might be interested. And certainly a number of local and national presentations that were dissemination activities. I would also say as a physician, we're often in a situation where we're thinking about patients, and we should be. The individual patient should be the focus of attention. But what I found very intriguing and satisfying about this work was to begin to think, well, wait a minute, we're focusing not just on individuals who are taking the classes, but the community, and the community for us was the senior center. So this idea of coming out of this ivory tower and understanding that there are other perspectives, and in particular thinking about health at a community or population level was important, and was an educational experience for myself. The ability to study diverse patient populations or client populations, personal education about the importance of cultural issues. So again, you heard this morning about the principle of co-learning, that both sides are learning. And for me, one of the principal learning lessons was how important culture is in thinking about how people think about health and present or don't present with certain health issues. With Carla Booten Foster, I co-teach a course now in CBPR, trying to take some of this knowledge back and infuse it within the academic setting of Weill Cornell. So we were not successful. We wrote a number of grants to NIH to try to sustain this work and build on it, to take the adapted model and into additional senior centers in New York City. We were not able to do that. But I can say, as a consequence of the work, other projects and initiatives that we did submit have been funded. One I've mentioned on the slide, where the elements of the program, which are self-management techniques, we took into the home care setting and taught 400 physical therapists how to administer them, with the idea that home care setting would be an appropriate place to disseminate this kind of program. I think another benefit of this approach is an ongoing relationship that I have with the senior center directors, and in particular with Evelyn. And I think this has come about through trust that has been built up over a number of years, through having ongoing dialogue, and also looking out for opportunities for collaboration. I've mentioned just one here on this slide, where Evelyn and I teamed to write a little primer on community-based supports and services for older adults, for clinicians, where again the idea is, if you inhabit in the healthcare world, you often are very clueless about the range of services that are present in the community. Physicians rather, I should say, and many other healthcare providers simply don't receive this kind of education. So I'd close, and Dan is a big part of this and mentioned it earlier. We are very invested in using CBPR in another area, and that is in the area of community-based palliative care. And we're really targeting a variety of objectives. The first is to enhance community awareness. We've come to that realization through our needs assessment. We're very committed to this idea of developing innovative community-based models to deliver palliative care outside of the hospital setting, and also thinking about building the workforce at a community level. And that was one of our projects that was recently completed, which was a palliative care educational curriculum that targeted case managers at some case management agencies in the city. And more broadly, the goal of this work is to improve the quality of life for underserved older adults with advanced chronic illness and their families. And as Dan mentioned, the primary partners are Brookdale Center for Healthy Aging and multiple community agencies, I would say, in East and Central Harlem, as well as the agency, the last one that is on the slide, the Translational Research Institute on Pain in Later Life. And I think that is the last slide. So if Professor Herman.
Well, I just wanted to add some benefits and challenges, because we sort of rushed through as well in terms of our participation. Dr. Rim talked a little bit about the fact that both of us have come from larger institutions, and there's all of the paperwork and bureaucracy that you have to go through. So having involvement with this community advisory board really sort of brings it back to the residents themselves, what their concerns are, what they need, and people kept talking about access and lack of access. People kept talking about sort of a discomfort and mistrust of the medical system and maybe physicians. And we realized that one of the things that is pretty true of palliative care is that it ends at the doors of the hospital. There are outpatient ambulatory programs, and there are a few programs that are home care based, but not that many basically because of payment issues. So this really had a lot to, in terms of an advantage, it really was a tremendous advantage in terms of sort of giving us the idea. One of my colleagues at Brookdale came up with the idea of, why don't we go to a hospital? And don't you have a connection with Metropolitan? There's also another sort of thing in terms of our continuing partnership. Since the first time I talked to anybody, and the first person I spoke to about doing this project at Metropolitan was the executive director, because I knew her. And so she sent me to the medical director, then sent me to the chief at that time of palliative care. And now I've met a whole new cast of characters because there has been a lot of turnover, and there was accreditation in the midst of that, and CMS review. So those are some of the sort of challenges, but people have been incredibly welcome. And one of the things that Dr. Rim said really the first time we started talking about this was, nobody wants to study our patients. These people aren't really looked at, and their needs are not listened to, and their voice is not given. So that's a tremendous advantage of our connection and our partnership, that regardless of what happens in this particular study, we know that it will continue. We're already talking about things that we want to do next.
Thanks. Thank you. So I had a couple of questions which I was given and which you were probably given as well, some of which you've already addressed. But one thing that I wonder about, so it sounds like I've heard from kind of two sets of research provider partners here. One, which it sounds like has a very long-established, productive relationship, and one that's kind of hoping to sounds like maybe build on some of that experience, but sort of at an earlier stage of development in terms of a project. I couldn't quite tell in the program of research, really impressive that you described. You didn't really talk about how long this took to establish and to kind of build the program, build the relationships, build the capacity, but I suspect it didn't happen overnight. So could you talk a little bit about kind of the sort of the process that you see, or the arc of development, which might have implications for the development of other work?
So Neighborhood Shop is the member agency of what is formally known as Council of Senior Centers and Services. And apparently they have been approached by CITRA to look at how CITRA can connect with community-based organizations that serve older adults. And through that that vehicle, we were introduced. Mm-hmm. And particularly because Neighborhood Shop is such a major provider of services to Latino elders in the Bronx, it looked like this was a good match for this particular endeavor. So we took a third party to bring us together. Mm-hmm. And that party also had a lot of credibility. Normally, what would a small nonprofit agency in the Bronx serving Latino elders, another very often overlooked population, have to do with Cornell University, Cornell, while in the Upper East Side. So that was bringing a resource to our community that would not have existed if it wasn't for this research. That's a wonderful benefit to our program. So, but that kind of set the tone for the beginning of the relationship.
I couldn't agree more. I would think of it as, really, you mentioned a matchmaker. They were the matchmaker. And I'm certain that had they not been there to say, these people from Cornell are okay, probably wouldn't have gotten through the door. So how important it was to have them broker the deal. So the trust factor that is so important, and you heard about through the morning and this afternoon, I think was dealt with in that way, that there was somebody who could vouch for both parties.
And can you just say a little bit about how long your groups have been working together to produce?
Well, let's see. I think we started the project. You and Carl and others have worked together on some other initiatives that may go back to 2005. So
probably
we're talking about a 10-year partnership.
Yeah. So it's been quite a while. Because my sense is that, and I've had some experience like this personally, that to be able to sustain a productive relationship over that period of time, or over the period of time it takes to actually get this work done, can be challenging. And so,
and it has changed. So initially, it was an opportunity for us to bring in a direct service for our clients that we could not have afforded. So this was an opportunity to hire our participants to take the training of the Arthritis Foundation and be paid for to be able to conduct this 8-week series. It also provided funding for another participant who had an educational background that could conduct the surveys in Spanish. That was the other issue. Cornell did not have the capability to conduct anything in Spanish. We did. So that's where we met and looked at the surveys, the instruments that were used, and what would be the proper translations, and we worked very hard on that, including people in Puerto Rico that, we sent things to have them double check, because I speak Spanglish very well, but, that's not what we were trying to promote. So to have minority elders be involved in research, this is a very empowering thing, because they felt nobody asked us these questions before. Nobody was interested in what we thought was happening to us. And wow, people from Cornell are actually coming here and talking to us. This was a very empowering moment for them. And that was something that, there are benefits that don't have dollar amounts attached to them. This was our greatest one.
We thought it was so important that these documents go down to Puerto Rico to be translated that we personally took them down there.
Well, that was a selfless. Is there anything, it strikes me that the experience that you're describing with Dr. Loriana's organization in some ways may be different in some fundamental ways from the kinds of challenges that maybe Dr. Gardner and Dr. Rim are going to face developing work at Metropolitan Hospital. Just the fact that, as you were saying, this is a public organization, part of a very large bureaucracy, considerable amount of staff turnover, it sounds like, at the senior leadership positions. Is there anything that you might be able to?
I think there's a lot of logistical issues that are more involved in how we do things, but a lot of the core elements are really the same. In any partnership, it kind of has to be somewhat of a symbiotic relationship. So when I'm listening to what's going on with my counterparts, it's both sides of the table are getting something out of it. So obviously the ivory tower is looking for their database. But on the community level, I hear they had access to a service they wouldn't be able to afford otherwise. They're empowering their participants so that they're taking more ownership and gaining some self-fulfillment out of it. So I think regardless of what the logistics of any relationship is, at the core it has to be each side of the table is getting something that they find particularly useful. One of the reasons why I was interested in doing the study is, again, empowering my own population, but also looking at our population and saying, why don't they come back? What are some of the barriers to the services that they may be eligible to get but they don't get? And then ultimately, what are the ways that we can kind of rectify some of those situations? So that's what's coming out of it from my aspect of it, and what I think will be beneficial to my patient population. So again, it has to be, each side of the table is getting something useful out of the whole partnership.
Yeah, and I would say it has to be genuine. It's not something that you can just, you might be introduced to somebody, but there may not be that sort of genuine belief. Dr. Rim, because of the structure of the IRB, had to be the internal PI, principal investigator of this study. So she had to go through a tremendous amount of paperwork and whatnot, and also deal with my anxiety, because I was constantly calling her up saying, has it gone through yet? Have we done this yet? And that's an incredible sacrifice for somebody who also is running a service. But I think the fact that we both really bought into the idea, we really think it's an important topic. We really think these are important residents, older adults, and I think, we'll both learn different things about the services, but it can only help but enrich the services, and I'm hoping it will also help enrich our greater understanding about the needs of Latino and African American elders with chronic illness.
I think it also ties into the panel that was on before us, where they were talking about passion. You really have to want to do this. It can't be just something that looks good on your CV, or that you're doing for the pure professional academic aspect of it. It has to be something that you genuinely care about and you want to see through, because it's at this point it's really become more a labor of love than anything else.
Yeah, I was going to say, as someone whose job is in a academic institution with some responsibility for trying to foster scholarly development and research at the faculty level, I can see that the incentives are complex because, both, as you were saying, at the community provider level, I can imagine that in some organizations, there may be a variety of concerns and other priorities which can take precedence over the time it would take to work closely with researchers. And at the academic side, there are also a variety of pressures and incentives which sometimes may divert or run counter toward faculty getting involved with these kinds of very intensive, long-term, complex relationships with community organizations to produce research, as important as it is. So I'm wondering if any of you might speak to those issues, like from your experience in the institutions and organizations you work with. Like, have you felt as if this kind of work is something that's highly valued, or that organizations and institutions could do more to help promote this?
Well, I would say I'm not so sure valued, not valued. I think maybe neutral. There is a hierarchy, as many of us know, in academia, where bench basic research seems to take precedence over clinical research, and clinical research that happens in a community sits lower down on this food chain. It shouldn't. But that's the reality in the world I inhabit. But I'm quite comfortable doing the research in the community, and once you come out, it's hard to go back.
So I can say, I'm not going there. But I can say from a community-based organization, I've been, it's the old Sullivan Show. I may be dating myself, but there was a guy with the pole and the plates,
Yep.
and he kept, moving the plates around and making sure that the plates didn't fall on the ground. I have a lot of plates up in the air,
Yeah.
and I don't have the luxury of saying, oh, I think we'll do a research study. No. Am I going to meet payroll? Is that client going to be evicted, if I don't intervene, or I have staff go in there? So there are a lot of other priorities, competing priorities. So I think it has to come from the top, the administration. If I didn't have an interest in doing this, it would not have happened. Mm-hmm. So it so happens that I am, I like this kind of thing. And I needed to have credibility brought to my organization as well, and having that relationship leads to credibility. So it has to come from the top, because there are just too many other things going on to be able to say, well, this isn't going to help me right now.
So Evelyn, I'm curious, it's my understanding that the funding soon will be predicated on the idea that all of the health promotion programming within senior centers is evidence-based. So is that a good thing in a sense that it might be a facilitator of more partnerships, or is it just one more requirement that gets in the way of doing work?
It's a little bit of both. However, having had this 10-year experience of doing this work, it's not something new for us. We already have the experience. We know it's doable. We can do it. And that helps us. That puts us ahead of many other organizations that are vying for the same pot of money. And that's why we were successful in getting that innovative senior center contract, because we did have that experience. So it's based, yes, we have to do more evidence-based programming because everything is now based on outcomes. And we have to prove that what we're doing is effective. And that's not just at the academic level or the clinical medical level, but it's also happening in social services as well. And so to be able to prove that, that we have a track record in this area is something that really puts us ahead of the pack.
I just want to echo, I'm of all of us on the panel, I'm from the most traditional academic setting. And, so the whole publish or perish, and I think that's part of what Dr. Herman was alluding to, that the idea of bringing in grant money and getting things, there's some sound, I like that, bringing in additional grants and getting out publications, all of which is slowed down when you're doing community-based work, is a balance. I feel the same way in that, it's so much more fulfilling to do community-based work that it's an important thing for me to do as well. But I wouldn't be able to do that if I didn't, if my dean and our dean of research didn't support that. We're up in East Harlem, and part of what I am sort of evaluated on every year is the service that I'm doing in the community, my engagement, how respectful I am in terms of research and who I'm doing that research with. And that's, she's taking a stand in terms of that, and that's also, I think a difficult balance. But I wouldn't be able to do that if I didn't have a school, and I've been at schools where that was not the issue at all.
Just to follow up, how unique is that to this program, or do you have a sense that that's sort of an evolution where we're seeing, and maybe the audience has some examples. My own sense is that's relatively unique.
Yeah. What would you say?
I didn't hear the last thing you said. Your own sense is that?
That it's relatively unique, that it's the exception rather than the rule?
This type of, I don't know, I think there's, at least in our field, I'm detecting somewhat of a change, or I think a slow evolution, because I think that there's a growing recognition, at least in social services, and I think as well in medicine and in public health, that that research that is not well informed by community experience and is not carried out at the neighborhood and community level often has less impact ultimately in terms of improving health or social service outcomes in communities. So I think that, as Dan was saying, I mean, I think there's always going to be, a trade-off or pressures around what kind of research can be more easily funded or more quickly published, but the trade-off in terms of having impact in the community, especially at schools like ours, where there's a high priority placed on trying to improve welfare of the community. I think that still is paramount. So it's a really interesting question though, because I think there are conflicting pressures.
I think something that also, I don't know if it was mentioned earlier, we need to look at the diversity of our professional workforce. Because when we're looking at working in minority communities, are the researchers that are coming in, what do they look like? How do they relate to the people that they're studying? So we need to invest in having professionals that come from the communities that we're serving right now. Cultural competency is a major issue when it comes to research. That's the barrier that we're seeing all the time when it comes to why don't we have information about what's going on in the Latino elder community? Because we don't have the language capacity of the researchers to be able to conduct that type of study. So I think that's also, if you're going to do studies in urban areas like New York City, you have to have a workforce that reflects the community that we serve.
Yeah, why don't we take some questions now?
don't know how to turn this on.
Can't see you very well. I see this.
Okay.
There we go.
Good afternoon. I'm Barbara Hart, and I'm the Executive Director of the Bronx Health Link. And thank you all for commenting and bringing your experience today. The entire symposium today has been just a joy to experience. But my organization is one of those organizations that can tell you that lots of times we don't know the opportunities that are available. I just recently, and I think it had to be an act of God, found out about the CTSC here, and I was able to apply and obtain a planning grant here at Hunter, And my partners are Shirley Yang and the stuff that she's doing, and I'm working with Lorraine Burns, and we're doing a grant on doula services in the Bronx. So, we in the Bronx are going to be introducing Weill Cornell to the Bronx, to their clinicians, to pregnant women, to preconception health, interconception health. But yes, it is an issue in terms of getting the information out. If we don't know that such opportunities exist, we're not able to take advantage of them, but when we find out about them, like when I applied for the grant, I remember thinking, I'm from the Bronx, they're not gonna give this Bronx, this planning grant, especially for doula services. Most of the time, people don't even know what doulas are. Do all of you up there know what doulas are?
Yes.
I do.
Okay, all right. So it's one of those things where if you get the information out, people will apply. In my community, I live in Central Harlem. I was born in Central Harlem, and the hospital that's closest to me is Harlem Hospital. And my church is the Abyssinian Baptist Church. Okay, I have Reverend Calvin Otis Butts. We're very much involved with various health activities and partnerships that's going along with Harlem Hospital. We have a gay 90s ministry. In order to be a part of that ministry, you have to be 90 years old and older. That ministry is extremely active. We do many things with them with the health ministry. We go on walks, we have dances. It's hard for me to keep up with them, One of the questions that came up in one of our discussions is, and I wanted to have this question for you as well, do you look at the sexual health of older people? And when you say older people, what age are you talking about? Because I think of older as 90 and above.
Well, I'm an older person. I'm over 60. According to Department for the Aging, they use the federal guidelines for defining old age, and it starts at 60. So here we are. Maybe some of us here are older people, right? It's important to understand that more and more, as the competition for funding increases, and it's there's a lot of competition for planning grants. Looking at underserved communities gives you extra points. Looking at innovative, creative things to do in the community gives you extra points. So I think that we're going to be seeing more and more funding to these smaller projects, planning projects in our communities, by virtue of the fact that the people that are making the decisions now, they've run out of players, so to speak. And I think that we have a greater opportunity for funding. But that's a personal opinion. But I'm seeing it happen in my organization as well, where contracts, proposals that I thought I didn't have a chance, now we're getting attention. So all it takes is that first one, to get that first one, to open doors further down the line.
The question I kind of heard was, how do you find out about this information?
Mm-hmm.
And I think a lot of times it's kind of luck, to be perfectly honest, and will. I think a lot of it is if you have initiative and a need, and in this day and age, a Google search is kind of what ends up happening. I mean, even our collaboration was kind of a lot of luck and a need, and let's find out if this will work. And I think that a lot of people in communities where they're traditionally underserved initially think it's not going to happen, so why bother? And I think that's the mentality that has to change.
Can I add something to that about getting the word out to community organizations. I'm Amy Confer from Drexel University down in Philadelphia. So we have a Philadelphia-wide community-driven research day that's about building these partnerships between community groups and researchers. And one of the ways we get the word out to community groups is putting it in community newspapers. So first of all, we have community members on our planning committee, but there's newspapers out of community groups, out of neighborhood associations, civic associations, things like that. And that's the way we get our word out to community groups about this pilot funding. So if that's another idea.
Two thoughts. The first is in regard to the first point around how do you hear about these things. You know, the CTSCs, and there's 68 of them now, I think, in the U.S., all of them have to, by mandate, have a community engagement core. And it's curious that some of them are quite engaged in engaging communities and others aren't. But it strikes me that it should be something where community engagement cores are systematically letting potential partners in the community know what the resources are. So there's an educational piece that seems key. And one way that may happen is, as this person just described, some kind of matchmaking where people who are interested from the community may come and engage to learn about what funding opportunities exist. And then the second point around the sexual health, I'm a geriatrician and work over at New York Presbyterian. We asked this question a few years ago of our patients. We had a survey. One of our fellows was very interested in understanding clients, residents that we serve, what their attitudes were, their willingness to open up and talk about sexual issues with their doctors. And most importantly was the question, do you recall having a discussion with your provider in the last year about your sexual health? I'm ashamed to say that about 20% of these adults said that they'd had that conversation. So it says even in an academic place like Cornell, clinicians are not doing what they should, which is to routinely be asking these questions.
So because I run senior centers, these questions are asked all the time, and we conduct workshops on sexual health. We bring in speakers from ACRIA on AIDS in older adults. I participated in a blog for the New York Center on Elder Abuse on dating violence for older adults. So this is a conversation that's had may not be having with the doctor, but they certainly are having them at the senior centers, where there are opportunities for people to get together. And this is, all our senior center directors take training on this issue, and we make sure that we bring in speakers to discuss this at least once a month, because it is a big issue at our senior centers.
I just wanted to add that Dr. Laureano was talking about cultural competence being important, and I think we need to realize that cultural competence also applies to age, and that a 50-year-old is not a 65-year-old, is not a 75-year-old, 85-year-old. It is our most diverse population on many, many different levels, and part of what the importance in terms of sort of like doing community-based research, one of the most important things is doing things like at Brookdale, before we did this big needs assessment, we went to the community boards and talked about who we were and what we did. I talked about it at the CAB. It was talked about at the HHC CAB of CABs. So just to get the word out there, because people weren't necessarily thinking about the fact that older adults and were living with multiple symptoms, and that was an issue that they were particularly paying attention to. They worried about symptoms, but that wasn't, they were thinking about other things when they thought about older adults. So part of it is also that it's about educating people about. We don't have to educate the service providers, obviously, but educating other, clinical providers, academics, researchers about the needs of older adults from a variety of backgrounds.
I just wanted to add to what Dr. Laureano was saying about the, you're talking about building capacity at the academic, in the academic institutions to be able to work effectively with community organizations and plan and effectively develop solid research relationships. And I think that the issue you raised about cultural competence and having researchers, academic researchers who come from the communities that they're going to be working with as research partners is I just wanted to reinforce the importance there. And that's obviously something that, you have to go back in the pipeline to be able to begin developing those kinds of people and bringing them, helping them get through to get the kind of training and credentials they need to then, form that workforce. And that's certainly a priority, for instance, of our school, and I'm sure a number of other institutions here at Hunter and in CUNY. Any other questions we have? Anybody else back there? That's a first. No?
We answered all the questions.
Last words from the panel, or, Yeah, is it at 5? When's the final speaker? Oh, good idea. Okay, well, I want to thank the panelists for a really edifying conversation and the audience. And I think the awards are going to be given now, and then we'll have a little break before the closing plenary talk. Sure.
Such an efficient group here, wow. Answered all the questions and